Hi, this is Elliot Fishman, and let's go on with part 2 of the role of cinematic rendering in the evaluation of complex vascular injuries of the lower extremity. So we looked at a few cases before. Let's look at a few more cases and show you the value and some of the challenges in this technique. Here's a patient with a right subtalar joint dislocation and talar fracture. Patient presented to the ED being a pedestrian who was struck in an MVA. The CTA of the lower extremity showed the open subtalar dislocation. 3D confirmed the extent of the fracture, including the posterior lip of the talus, and the patient was then taken to the OR for reduction and splinting. Very nicely showing you what probably you would see on physical exam, that open injury, the marked disruption of the ankle joint, really this complete dislocation of the subtalar joint. The coronal images really nicely show you as well the vascular mapping. The oblique images show a fracture fragment superior to the calcaneus, which is on that yellow arrow, originating from the talus rather than the calcaneus. And again, the complex nature of the fracture. Again, think about rotating this 360 degrees, but I chose select images which really give you a good feel of the fracture, the orientation, as well as the vascular map. Another patient, anterior tibial artery contrast extravasation in a patient in a motor vehicle accident with an expanding hematoma. So they really were concerned for active bleeding. And what you'll see on the imaging is a large hematoma in the anterior shin subcutaneous tissues with active extravasation from a branch of the anterior tibial artery. Very nicely, you can see some of the packing on the patient's wound. You can see whether it's on the MIP imaging, and the second image B is classic volume rendering, or in the cinematic injury display with muscle and bone and vessel. The patient's very nice example of the active bleeding from the anterior tibial artery. The detail as to soft tissue injury and as to muscle injury, the lack of bony injury, and really good visualization is very nicely shown on these 3D images. Now, when we talk about vascular occlusion, vascular spasm, it's one of the things I think that's always a challenge to me, because if there's spasm, I don't see flow in the vessel, obviously, but then I want to know, is the vessel occluded or not? Occlusion, the patient goes to surgery. Spasm, you just watchful wait typically. So we talk about narrowing occlusion of the vessel lumen can be due to dissection, spasm, thrombus, or external compression. Vasospasm is a transient luminal narrowing with complete resolution over time, so you can sit on the patient. However, dissection and thrombus can present when it's an intraluminal filling defect. It's easy. When dissection has a flap, it's easy, but sometimes you just look and you see a 3 or 4 centimeter gap, for example, in the superficial femoral artery or anterior tibial artery, and you see some hematoma, but not a big hematoma. And the question is, how you're going to read that study becomes somewhat challenging. So some examples. Here's a case of SFA occlusion with a distal femur fracture. The patient had a ballistic injury to the right upper and lower extremities. The ankle-ankle index was 0.4, which prompted the patient's CTA. And what it shows is a short segment of complete occlusion of the SFA at the level of the distal adductor canal with distal reconstitution, and a comminuted fracture of the anterior medial distal femur with patellar displacement. Image on the left and the middle image are both classic volume rendering. Show you the gap in the patient's SFA, a couple centimeters worth, and you can see it very nicely as well on the cinematic rendering. With the CR, we can appreciate with more detail several of the bullet fragments distal to the region of the SFA cutoff, suggesting possible bullet track. CR also provides better anatomic detail of the comminuted fracture of the anterior medial femur compared to the other images. So again, all of them show the occlusion of the vessel, which is not surprising. Again, I mentioned MIP is particularly good at that, but cinematic rendering gives you more information and more detail. Another case, tibiofibula fracture and partial occlusion of the anterior tibial artery. Again, this was a gunshot wound. Gunshot wounds are probably the thing that is most challenging in terms of looking at vascular injury. And really, you need to make rapid decisions because of management. And what you'll see in this case is luminal narrowing of the anterior tibial artery at the level of the comminuted fractures, and the patient was taken to surgery for intramedullary rod insertion. Again, the MIP imaging with bone removal, and then 2 cinematic renderings, one with all the muscle removed and showing you nicely the tibia and fibula fractures in the vascular map, and the other one showing you the fractures but also putting the muscle back in place. The cinematic rendering is especially useful in the context of severely comminuted and displaced fractures that could potentially injure surrounding vasculature, muscle, and soft tissue. Again, putting all these images together really gave the surgeon all the information they needed to take the patient to the OR and do it very, very confidently. Another case, popliteal artery occlusion. Patient was hit by a car while on a motorcycle. He was found 100 feet away from the site of the accident. CT of the abdomen with runoff study showed the comminuted and displaced right and left femoral mid to distal fractures with short segment occlusion of the right popliteal artery. Injuries also included proximal descending aorta dissection with multiple flaps and associated hematoma. Patient went to surgery. A combination of vascular and orthopedic surgery took care of the patient. Again, this whole body scanning, the volume rendered image on the left and 3 cinematic rendered images showing you the comminuted fractures of the mid to distal third of the femurs bilaterally. There's no dislocation at the hip or at the knee. The patient's vascular injury to the SFA on the right side, the 2 centimeter or so gap in filling, very nicely shown on both the images from anterior projection, which is labeled C, and posterior projection, which is labeled D. Again, the ability to rotate the images, interact with the images, and take snapshots of the best images really works out very nicely. The photorealistic quality of CR reconstruction provides more detail regarding the angulation, rotation, and displacement of the fracture fragments, as well as their relationship with the nearby vasculature, very nicely shown. Another case, occlusion of the SFA and popliteal artery. It was a 7-year-old who was a pedestrian struck and pinned against a wall. CTA shows the right femoral mid and distal open diaphyseal fractures, but also the traumatic narrowing and inclusion of the SFA and popliteal artery. Patient was taken to surgery, and surgery, fortunately, was successful. But just really impressive, the displacement of that distal femur fracture. You can see when I take the bone away, the real gap nicely showing in the superficial femoral artery and in the popliteal artery. And then, of course, you can see the hardware in place for reduction of the patient's fracture over time. And again, a really, really nice visualization. You could see that that the photorealistic quality of the images provided by cinematic defines a subtle irregularity in the vessel walls that might represent developing pseudoaneurysms. These findings would have been missed and were missed on the routine CTA. By setting the viewing parameters to highlight muscle and soft tissue, we can appreciate the post-operative external fixation devices and associated soft tissue injury as well. So again, besides the diagnosis at time of trauma, which we see here, CT is also very good at looking at and understanding the reduction, whether it's successful or not, potentially post-operative complications, all which can be seen very nicely on this set of images. Another case, occlusion of the left SFA. 29-year-old man presented to the ED with a gunshot wound of the left thigh and no Doppler signal from his left dorsalis pedis artery. CTA of the lower extremity showed occlusion of the left SFA. Again, first I'll show you the MIP image. Again, shows you the SFA injury. Also the spasm a bit more distally in the SFA, which is again nicely shown in the patient's cinematic rendering, particularly nicely as we adjust the rendering parameters. The coronal 3D cinematic reconstructions demonstrate the finding but no active extravasation. The oblique sagittal cinematic rendering reconstruction, which is number D, shows the gunshot wound, entry wound in the upper thigh, as well as the tourniquet present. So again, combination looking at the bone, looking at the muscle and soft tissues, looking at the vessels. We're really able to define the entire extent of the patient's injury. So everything sounded great. Are there limitations? Well, first of all, it's the quality of the data set you start with. And this is CT in general, garbage in, garbage out. But it's important have the patient comfortable in the scanner. With fast scanning, we have very few cases where the patients actually move. If the patients are thrashing around and they can't remain still, I would really not do CT unless you can sedate the patient. Post-processing times, we talk about 5 minutes, but that's with filming and everything. You could literally do the cinematic rendering. You load the data, and instantly, in a matter of seconds, you can make decisions. So again, it's not going to be any longer than any other reconstruction technique. And again, it's becoming more available on different workstations. You can even do cinematic rendering on a Mac PC with a new Carbon technology from Apple. And again, I think I've shown you many cases of some of the advantages of CR compared to classic rendering. But again, we still use some of the classic rendering, particularly MIP, which is particularly good for looking at vessels. So I'm not going to say we don't do it because we do both of them. So concluding then, cinematic rendering is a promising technique for displaying 3D CT data, and we do it literally from the head to the toe. It provides photorealistic reconstructions of the lower extremity injuries, depicting important information in patient management, be it conservative or surgical planning, and it improves patient outcome. Application of these reconstructions into routine clinical practice and their advantages and disadvantages relative to traditional 3D techniques has not been assessed in a large study, but I think tends to be very obvious. It's just one more way of thinking about things moving forward. Now, if you ask me, how is this going to be in the future? Cinematic rendering will get better the better the data sets. Think about photon CT, the better the 3D reconstructions are going to be. I also think AI is going to play a major role in helping us create the images to be the best images and do them very quickly. Here's a number of references you could read. Of course, the key reference would be the article this talk is based on, which was on the second slide. And with that, I wish you a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.